My name is Lal Russell and I'm a researcher at the University of Nottingham. I'm presenting this study on behalf of the HORSE team, who are listed on the slide. The poster with references is included on the final slide. Over 20% of stroke survivors leave hospital severely disabled, but there is little published research to support the commissioning or provision of rehab for this population once they leave hospital. For the purpose of this study, we define severe disability as scoring a 4 or more on the modified Rankin scale. These individuals are usually not mobile and often require equipment such as stand aids or hoists to transfer from bed to chair. This level of disability often affects multiple domains such as cognition, communication and continence, as well as the more obvious physical impairments. Rehabilitation is routinely commissioned for stroke survivors after they leave hospital, but often excludes those who are unable to stand with one person, in other words, those who are more disabled. This has created health inequalities where the most disabled are often unable to access rehabilitation in their own home. The aim of this study was to establish what are the core components of home-based stroke rehabilitation for survivors of stroke with severe disability. Due to the pandemic, we chose to adapt the nominal group technique, an established method of gaining consensus in the absence of available research evidence, to an online virtual format. We used 2 panels with 7 participants in each. Limiting the number to 7 allowed participants to contribute fully, a breadth of perspectives to be represented, and discussions to be facilitated. Participants were experts in the field of stroke rehabilitation from across the country, including clinicians, researchers, and those with lived experience, in this case, a stroke survivor and an additional stroke survivor's carer. Prior to the event, participants received an e-booklet containing an outline of the nominal group technique and the adaptations made for the online format, a review of the literature, a scope of interest and definitions of key terms, and most importantly, the 2 questions for consideration. We also provided a framework for participants to organise their thoughts. This provided structure around which participants gave feedback, but wasn't intended to restrict discussion, and opportunities were given to capture any additional ideas generated outside of this framework. This approach follows 5 stages. Firstly, introduction of the group, explanation of both the technique and the research question for consideration, which you can see up on the screen. After the introductions, we had a silent idea generation, and this was done virtually on MS Teams, so the panel members turned off their videos and individually generated responses to the 2 questions. The panels reconvene and take it in turns to share their responses in a round robin. Everything is typed up in real time on a shared screen. Once all responses have been given, panel members have an opportunity to seek clarification from each other before the meeting ends. 5 days later, all panel members receive a list of the statements using an online survey platform, and they get to vote as to their level of agreement with each individual statement. 492 statements were generated from the 2 panels. Of these, there was positive agreement for 421 of them. These were analysed and aggregated, resulting in 11 overarching consensus statements. These are summarised in the infographics, copies of which are available through BMJ Online or via the QR code on the poster at the end. In summary, these statements highlight that survivors of stroke with severe disability have complex and diverse rehabilitation needs, many of which are shared with the wider stroke population. This study found many similarities with the existing consensus recommendations for stroke rehabilitation, such as specialist skills and team composition. However, there was an emphasis on family and caregiver support, as well as highlighting a need for greater flexibility for the timing of rehabilitation for this more disabled population. Comparable to previous literature, the virtual nominal group technique provided benefits such as the efficient use of participants' time without the need for travel, and the ability to bring geographically diverse experts together. In turn, this removed some of the barriers faced by stroke survivors and their carers when attempting to participate in research, such as transport, financial burden, and accessibility. As with any consensus activity, significant investment was required in the planning and provision of detailed information ahead of time to optimise participation. As a novel adaptation of the nominal group technique, an online survey was distributed to individuals following their participation to evaluate their experiences, and positive feedback was received, specifically regarding the detailed information prior to the event. In an era where the use of virtual platforms such as MS Teams, WhatsApp or Zoom becoming commonplace for healthcare professionals and academics, they may also be accessible to patients and their caregivers. The virtual nominal group technique has the potential to further level the playing field for those groups of individuals who may face barriers to participation in research and make consensus building truly inclusive. I'd like to thank our panel of participants for their input and our funders for their ongoing support. If you have any questions, please get in touch. Thank you for listening.